Cool. Perfect. All right, everybody. This is Eric with Motion Guidance, back for another round with somebody that's just been a really nice meet and greet over the past couple of years with me, and somebody who's at the top of the food chain, if you will, about clinical neuroscience, and that's Dr. Matt Antonucci. So welcome, sir. How are you doing?
Hey Eric, I'm doing great. Thanks so much. It's always great to see you, and it's always great to hear your voice. So thanks for inviting me to kind of have this little talk.
Yeah, great. I know from following you on social media channels, you've been really busy for the last couple of years, and you're integrated into a lot of different things. So why don't we just start with you telling everybody that's going to be listening to this kind of your credentials and background, and then, maybe some of the other big name things that people would recognize you from.
Yeah, sure. So my background started in chiropractic. I went to chiropractic school, Life University in Atlanta, Georgia. During chiropractic school, I really got enthralled in the neurology and chiropractic, but then more so in neuroscience and functional neurology. I met Dr. Carrick at that point early on in chiropractic school, probably my first or second semester, and I was just so intrigued and inspired to learn. I wanted to be Dr. Carrick. Realistically, I just wanted to be able to do the things that he did, help the people that he helped, and know the things that he knew. So I just kind of bit the whole sandwich at one time and just said, I'm gonna do this, and committed wholeheartedly. I traveled all over the world following him. Anytime he had a speaking engagement, I was there sitting in the front row and tried to absorb as much of his knowledge as I could. So that's a little bit about me. I'm 4 or 5 times boarded through the American College of Functional Neurology and vestibular rehab, childhood developmental disorders, also in neurochemistry and nutrition. And I'm also the president of the American Board of Brain Injury Rehabilitation. So I try just to diversify as much as I can. Realistically, when you know the nervous system, it's the same whether it's in adults and in children and all these different types of conditions. But all the little different conditions have their idiosyncrasies. So it's good to be able to understand conditions in their entirety.
Yeah, that's fantastic. For those who might not know, um, Dr. Ted Carrick, who you mentioned before, really big name in the chiropractic arenas and in functional neurology. And as I've had it explained to me, he's kind of built a name off of bringing people out of comas. Would you like to speak to that for just a second? That's kind of a very unique way, obviously, of kind of getting your name known out there.
Yeah, I mean, honestly, it would be tall tales if I didn't see the old VHS tapes. So Dr. Carrick has recorded every single case that he's ever attended since 1979, and some of those we literally at the Carrick Institute here we have a VHS player where we can go in the storage unit, pull out some of these tapes, and learn from the things that he used to do back in the day. So he made a big name for himself in the late 80s, actually, starting to do some of that work. He realized that chiropractic as a modality realistically is less about the periphery, bones and joints and cracking joints and things like that, and more about the afferentation from the muscle spindles, the Golgi tendon organs, all the mechanoreceptors in the joints that create changes in the central nervous system. And he has a whole bunch of papers that he published on that. So he started applying that work to a myriad of different types of patients. It first started with people with chronic low back pain, workers' compensation, but then it started moved into things like coma work, movement disorders, concussion, traumatic brain injury, and he back in the 90s he was known for this work in coma, and hundreds and hundreds of patients all over the world that he's worked on in comas. And that kind of faded off just because, from what he tells me, he kind of he kind of had an ethical or not ethical, a moral dilemma because sometimes he would help these patients wake them up out of comas and they had terrible pain syndromes or altered states of consciousness and they wish they never woke up.
Interesting.
So yeah, he started saying, you know what, this is a little too emotionally heavy for me. There's some big wins and some big losses. I think I want to focus on a different sort of elements of neurology, and that's when he started really getting more into traumatic brain injury. And then in the 2000s is where we kind of really dug in that area, concussions, mild, moderate, and severe traumatic brain injuries. Then everything kind of hit the fan, so to speak, with Sydney Crosby back in the 2012 era, where Dr. Carrick and I worked with Sid and got him back on the ice, and then that's where things went crazy, and everybody started looking for for a functional neurologist for their concussion.
Right. So that is just a perfect segue into that particular story, and you working with other, not only just big name athletes across the United States, but across the world coming to work with you. You learning from, such an icon. And, we originally met, I believe, in a conference in Florida, a chiropractic conference, when we were demonstrating motion guidance there. And then I've taken a few classes from the Carrick Institute. So we've gotten to meet up a few times there, and just always been super impressed. But we're talking about people like Russell Wilson, who now is a Denver Bronco. So that's exciting for us. So keep working with him, please. And
He actually just text messaged me. He's like, "Hey, when are we doing our next thing?" Yeah.
there you go. There you go. That's great. Victor Belfort, who else do I have on my list here? Simon Gagney, Lucien Boot. I mean, just some amazing names out there. And are you treating them as a current condition usually? Are you treating them preventatively, or is it a mix? What do you like to get your services out there for?
So it originally started with individuals who had concussions, because pretty much every professional athlete does. I mean, no matter what the sport, the people are hitting their heads. It's part of the course. When you have high velocity sports and there's a possibility that you slow down really quickly or bang into something, the chances of you having a concussion are through the roof. So it started off with individuals seeking care for concussion. And then what ended up happening is these individuals, when we put a good plan together and we implemented the way it's supposed to be implemented, they get well very quickly, especially athletes. I know there is some research out there about the athlete brain and how it responds to learning, and that's basically what we do, right? When we start looking at neuroplasticity and rehabilitation, we're teaching the brain to do things a different way. There are some papers out there that suggest that athletes learn motor skills a little bit faster than the average person. So where I'm going with this is that we start working with people in the middle of a treatment plan. They're like, I feel great. Should I go home, or are there things that we can do to make me, instead of 100%, 110%? And I kind of scratched my head a little bit and I said, I'm sure there is. Let's figure out some different things. And then people started going back to their franchises or wherever it is and said, hey, you know what? I went there for this concussion. I felt better by, let's say, day 3 or day 4. And all day 4 and day 5, we just worked on neurological optimization. And then people are like, really? So I'm really interested in neurological optimization. I don't have anything wrong with me. And then, so it's kind of like the split between the two different types of patients. We're still very largely focused on traumatic brain injury, but that whole performance, neuro performance thing is starting to get really big. I mean, Tom Brady's been doing it for years. He spends millions of dollars a year just trying to keep his performance at the top of the game. And then, other individuals like Russell Wilson the same way, LeBron James the same way. They're investing in themselves because they know that they are what their performance is. And if they're not taking care of themselves, and especially basically one part of our body we can't replace at these days, our brain, they know they need to take care of it.
So for the people who are going to listen to this, can you give 1 or 2 examples on neural optimization? So I'm sure there's going to be plenty of listeners who are familiar with, general ocular motor things and, cerebellar types of, training and, multi-system, multitasking types of things. But give us some examples for, neural optimization for people who I've either been down that road and now I want to prevent it, or I just want to make sure I'm always at my best, my peak.
Do you kind of mean like, what are people like looking for an example of what we might work on?
Yeah, sure. Mm-hmm.
Okay, so I think a really important one is peripheral fields, right? Peripheral vision. Every athlete that I've ever met says, if I can have a bigger peripheral field, then I can see more of the game that's going on. And realistically, we all have a pretty big peripheral field. It's just a matter if we're aware of it or not. Most of us can see 90 degrees on each side, our 180-degree peripheral field. But the thing is that when things are in the periphery, we tend to be, especially being on computers all day long and cell phones, we tend to start getting this tunnel vision associated with focus. So one of the things that we try to do is we try to measure that peripheral field by giving them things that ask them if they can see it, ask them when they can identify what it is or what color it is, and then we look for areas of poor performance. And here's a great example of this. you might have someone, and this is hypothetical, this is not one of my clients or patients, but you might have someone who is on a football team. And we look at their peripheral field, and they have different colors that we look at, like red, green, blue, yellow, and we start assessing how they see those colors in the peripheral field. Well, if someone does green, yellow, and blue really well, but they're really poor at seeing red, maybe in the right sided peripheral field for whatever reason, that opens up a whole door for opportunity. And what does that opportunity look like? Well, what happens if it is a quarterback, for example, that can't see red on their blind side very well, and the players, the opposing team wears red jerseys? So that's going to mean your sack percentage goes through the roof because you're not going to be able to avoid that person. It also has correlations to concussion prevention, right? Where you can see your peripheral field better, less likely to get a concussion. So that's one example. But I think an even more important example that a lot of people don't think of is neck, vestibular, and eye integration. The way those three things integrate for athletics. You know, we need to be able to move our head separate from our eyes. We need to be able to move our head with our eyes together, and we need to have different combinations of those things in a different planes. So this is where we use motion guidance a whole lot. We start looking at how individuals can start synchronizing eye and head movements, how they can start disconnecting eye and head movements, specifically with vestibular. And you know, this is such a passion of mine because part of the way that we come up with some of the therapies that we do is we look at the way, I mean, God or whoever you want to call it, the great creator created our nervous system. And we feel like, you know, there's nobody that could do it better, so let's not try and invent the wheel. If you start looking at some of the first sensory systems that develop, 4 weeks after conception, you have vestibular perception. You know, you have graviception, meaning the ability to perceive gravity, and we also have the ability to perceive motion. Not too long after that, we start integrating things into proprioception. So our neck muscles integrate with the vestibular system, and then we have vision that integrates with that a little bit later. So that triad of vision, vestibular, and cervical proprioception is so crucial for not just being a pro athlete, but to be an individual, a mom or a dad or an executive or anything, a grassroots athlete, because that's really important. So we work on things like that. We try to find blind spots for people, no pun intended with the visual fields, but functional blind spots that they don't know where they're compromised, and fix that. Because typically when you're either at the top of the NCAA or the best player on your high school team, or if you're the best in the NFL or something like that, you're done focusing on what to be good at. Now you're starting to look at the opposite of that. It's like, what am I not good at so that I can have a better whole package?
Right. So you're not just trying to mention like the function of the thalamus, but you're trying to say more metaphorically, like where your blind spot's coming from for
Yeah, yeah,
total function.
your
Yeah.
metaphorical blind spots,
Right.
exactly.
Yeah, very good. You know, interesting you mentioned that. I think a lot of people that we've gotten feedback from on the motion guidance system and starting to use it for those types of assessments, once you can actually see that you have, you know, little cheats, I guess is what we call it in my clinic, where people are doing a saccade, you know, a drill, and there's always a single side that they tend to be moving just a little bit, but they wouldn't know it until they see that laser move, or the hypofunctioning side on VOR, where that I've seen this countless times, and I would love to do some type of research on this. But you know, our typical assessment for VOR, just with the thumb out in front and moving back and forth and making them toleratedly dizzy, I guess, and sustaining that, you can see that they tend to gravitate toward a side with that laser, and they're not going toward the side that needs the integration. So I don't know if you guys noticing that down in you know, in Florida with what you're doing, and
Yeah,
but we get that feedback a lot from our users.
absolutely. I mean, it's like anything. I played baseball, basketball, I skied. I always had a coach. I always had someone, and I go to the gym every single day with my buddy, and not because of the companionship, but I want somebody to look at my form.
Right.
And you know, when I go to put 5 more pounds on a barbell or something like that, I want to know, am I doing it right before I put that 5 pounds on? And so my buddy will say, go ahead and do a couple reps. Let me watch and make sure. And if I'm doing the reps wrong, we don't put the weight on. So that's how we like to work with our neurological patients. We kind of say, okay, it's important to do it right before you do it a lot.
Right.
And that's where this whole coaching comes from. But yeah, we see exactly what you're seeing in your practice. We see that all the time, in healthy people, but also in people specifically that are injured.
Sure. Now, you mentioned before kind of a plasticity type of approach, with, a lot of your background and getting into traumatic brain injury and, the other things that you had mentioned. But you, I believe, are the director and one of the founders of Plasticity Centers. Is that correct? All right. So
Yeah, absolutely.
you want to walk us through that? Because I know that, so I'm in Castle Rock, Colorado is my home base. I know you guys have a facility here now up in the Denver area, and you have the original down in Cape Canaveral, Florida area. I think that's right. Or correct me, if I'm
Orlando.
getting off. Orlando. Okay. Yeah. So walk us through what Plasticity Centers is, and then we can, talk about one of the handles you have with at Plasticity Doctors for your social media for people too.
Yeah, absolutely. So Plasticity Centers was a kind of collaboration between me and my partner, who was really inspired by functional neurology and some of the changes that he saw. And like he's not medically oriented. He's not a healthcare practitioner. He's just someone who's more of a philanthropic person where he wants to do good for the world. So we started off in 2015 with the Orlando Center, and we just got so busy that what we started realizing is people were coming to see us from all over the world, and we had a responsibility to get closer to them. So we started seeing a lot of people coming from California, from Seattle, from even Colorado. So we said, we need to do something out west, and we love Denver. Denver's amazing.
Yeah.
So we opened up a center there. We also have a center in Atlanta as well too.
Oh, okay.
Yep, and then we have the original center down in Orlando. But so the way plasticity works is we have two different types of programs. We have what we call our intensive, and we have what's called our extensive. The extensive programs are more for local people that don't want to commit a whole week of their life to doing rehab. They'd rather come a couple times a week, kind of like the standard typical model that you see in PT and chiropractic, where it's 2 or 3 times a week, every week for a couple months, just until they get well, and then we discharge them. And then our intensive program is what everybody kind of all over the place talks about. It's where they fly to one of our centers, they stay in a hotel, and they come to our clinic for 3 hours a day, usually separated either 90 minutes times 2 or 60 minutes times 3. And we kind of do the same therapies over and over and over again, creating neuroplasticity, just making them a little harder. And some people are like, well, that's kind of strange. Why do you do the same thing over and over again? And I always say that plasticity is learning. And how did you learn? How did you learn to do multiplication? You studied your twos, you did it over and over and over again. Then you studied your threes over and over and over again. And you made it harder and harder and harder, more challenging as you got better at the easier ones. And that's kind of exactly what our model is at Plasticity Centers. It's figuring out what you don't do well, either because of your injury, because of your developmental challenge, because of your degenerative condition, or just because you have a blind spot in your performance. And then we create a customized program for every single person. I don't think I've ever had the same patient do the same thing. And then we kind of implement that over our 15-hour week, mostly just to kind of get you a plan to go home with, so you can be medically autonomous, if you will, not worrying about going to the doctors and taking charge of your own health. And that's kind of the plasticity program.
That's fantastic. Is that a traditional chiropractic model of a cash-based thing? Or are you guys integrating some insurance-based things with that? Or what's available for people who want the community-based, every once in a while type of thing, or the intensive, either one?
Yeah, it's been such a challenge to get insurance companies to pony up for a therapy like this, just because a lot of the people in here have never heard of it. The insurance companies certainly have never heard of it. And even if they have, they want a decade worth of research behind it in order to be able to pay for it. And it's so challenging just because we're calling this functional neurology, but what is it really? It's vestibular PT, it's orthoptic training, it's neuromuscular reeducation, it's therapeutic exercises, it's chiropractic adjustments, but just packaged into one thing. Because typically you would have to go to how many different providers to get that? 6, 7, as many
Right.
therapies as I named. That's how many providers you'd have to go to. But it's just foreign for anybody to say, well, why is this all put together? And most of all, why are you doing it 3 times a day? That's crazy, right? I don't think it's crazy, but that's what the
Right.
insurance companies say. So it is a pay for yourself model, a cash pay model. There are financing options that are available depending on where you live. Some of our local patients have credit unions that will finance the entire program. Care Credit's been able to do it. There's a lot of people that do GoFundMe fundraisers and things like that. So, it's coming up with the money is sometimes the hard part. But the reality is that every person that's ever come through one of our programs says the value was more than the cost. So that's what we like to hear.
For sure. Well, and definitely a cash-based PT from the physical therapy side has been trying to build a lot of momentum over the past several years. There's a lot of advantages to that sort of model, I think. One of those being people know up front what they're getting into, and I think there's also a little bit of ownership for that too. Of the family unit is committed, the person's committed, oftentimes for that. And then you also have you get rid of the model that I run into, unfortunately, more than periodically on a diagnosis like POTS. And you do all your tests, you submit everything, the code should be good, and you'll have insurance is just 3 or 4 visits deep say, no, we're not covering that. And then you have to go back and pick up all the pieces, and and those people need help. I mean, there's dysautonomia types of conditions. Once again, it's very specific to the individual, right? So I know you guys have a lot of resources that you have at your disposal at those types of clinics. Other clinics might not have that much, and they have to kind of struggle through a little bit, but it has to be individualized. And when an insurance company takes that away, the cash model kind of supplants that with, we can do everything we need to do, and up front what's going to happen with that. So
Yeah, that's exactly right. And one of the benefits of that, and I tell patients this, is that when you come to see us, we're getting everything that we can possibly do with you. We're doing video oculography, we're doing posturography, we're doing cognitive testing, we're doing autonomic testing, where normally in that situation, what you would have to do is say, oh, okay, let's do your physical examination. Okay, so you have, for example, you have POTS. Okay, we're only going to be able to do autonomic testing. We're not going to be able to get your insurance to pay for video oculography or posturography. And that's because we can kind of go on a long tangent about this. My opinion is that we've been so used to a mechanistic systems model, a mechanical systems model, where you look at joint angles and we look at, okay, you're 20% better than you were before, not an information systems model. Our brain, our nervous system is an information system. It's not a mechanical system. And the reality is that in order to look at an information system, for example, like a computer software, if you have one character of code wrong in a software, the entire software cannot work, right? However, in a mechanistic model, if you have one muscle that's not working well, somebody can still bend their arm and things like that. So in order for us to figure out how to help somebody, we really need to look at the gestalt, the whole picture, and get all of the information, because sometimes vestibular aberrancies can cause dysautonomia. Sometimes cervical proprioceptive error can cause dysautonomia. Sometimes oculomotor dysfunction can cause dysautonomia. And sometimes it's primary with like a genetic condition. Sometimes it's inflammatory with autoimmune. So if you didn't do all of that testing, there's not really any way for you to figure out, how do I help this person? And that's, going back to the conversation, is that's where the insurance model starts to fall short for some of these patients, because they're looking at it as mechanistic. You do this when you have that, and that doesn't work for patients. It just doesn't get them the results that they need.
right. Even delving further into that, more and more research that keeps coming out. I mean, we can't rely on imaging to tell when a person has a problem. Most times, I'd say it is a fair synopsis of that. We can't rely on special testing a lot of times to necessarily tell us what's involved. We have to go based on the reactions of the patients. And I know that's where you dive into with your practice extensively. Of we're looking for not just the treatment portion of it. We're looking for the change to normalize the system, get it to work optimally from there. And I just think that's the best approach you can have for no matter what science you're into. If you are into the nutrition standpoint, you can't have a one size fits all for everybody. Designing those exercise routines, you can't do it for rehabilitation, you can't do it for medicine, even though I unfortunately have to say the majority of people do that, right? Just kind of, here's what you get if you fit this box.
Yeah, well, and that's the thing is that the box phenomenon is what I call it. Where people are put into boxes based upon their diagnosis. It's because we've been so diagnosis oriented for so long. You have strep throat. Here's the antibiotic for strep throat. The whole functional paradigm, whether it's functional medicine, functional neurology, functional cardiology, I love it so much because it's not disease focused, it's process focused. Now, ultimately, we know that a process can go forward or a process can go backwards. Typically, a disease is an endpoint. It's you have cardiac failure. Okay, how do we go back from that? You can't.
Right.
But if we start looking at functional cardiology, we say, hey, you know what? Some of your lipid, levels are off. Some of your C-reactive protein, your inflammatory, you're moving on this process towards cardiac failure. Let's do some things to move you backwards. Taking that and put that into neurological terms, you can just be diagnosis agnostic. You don't. Your patient can come to you and say, I don't care what you have. We're going to look at the function because we know you're somewhere on this process, and the process needs to move away from disease and more towards high functioning. And it just kind of it allows things to be fun. It takes some of the pressure off of everybody. And we're in a time right now that nobody likes to be labeled, right? Whether it was race for a while, now it's sex, and a lot of people are just wanting to wipe off the labels. This applies to patients as well. Nobody wants to be called autistic. Nobody wants to be called demented, right? So if we can start looking at this process orientation of neurology, all of a sudden patients get so happy, doctors start having fun because now they're going to start seeing changes and things that they can actually do to help somebody. So that's what gets me so excited about this functional paradigm, especially in functional neurology.
I think you mentioned a great word there is, clinically, especially after the last couple of years, but even before that, some people with burnout or, whatever that is. I think clinical practice needs to have that element of fun. And if you are an investigator rather than just an implementer, it usually is pretty fun
Yeah,
if you have that sort of mindset. So doesn't matter, again, your background of rehabilitation or medicine there. If you have that mindset, and I know you have it, I know people around your world have it from meeting some of them, and that's who I try to stay close to on my side of the world. For those is that clinical practice should be fun. If it's not, you might need to be looking for a change or some different education or something there.
yeah, that's exactly what it is. And there, I mean, you're only limited by what your scope of practice tells you to do. So if you're kind of feeling like you're stuck doing the same thing, kind of on the hamster wheel, just see what you're allowed to do, and then try and branch out. Because I've been teaching now for almost 14 years for the Carrick Institute, and I see so many people that come to one of our courses that have been on the hamster wheel, and we teach them just one thing different. I mean, obviously, we try to teach them more than that, but if they
Sure.
take home one thing, they bring it back to their practice and they say, you know what? It's crazy. That patient just walked in my door. And the reality is that patient has always been walking in your door. Now you're just seeing at it, but you get so excited when you say, I just learned this. Now I saw this with the patient, and now I know what to do to help that person better. So that's the cool part of practice. It's called practice for a reason.
Right.
You should be getting better at it.
That's right. That's right. That's right. That's a great way to put it. Let's see what else I have here. So tell us about where we can find you on social media, and how, if people are interested, if they can contact, anyone in, kind of your facilities or anything like that.
Sure. So all my speaking I do through the Carrick Institute. So if somebody is looking for, I do, gosh, I did 28 weekends in 2019, right before COVID, conference presentations for associations. I love doing that stuff. I love taking neurology and making it easy to understand and digestible, but more importantly, implement it into practice. So yeah, anytime somebody wants me to do a speaking engagement at some point, whether it's digital or live, the Carrick Institute is kind of where I do all of that through.
Okay.
As far as they're carrickinstitute.com, and I'm sure you can find them on social media. I don't know what their hashtag. I think it's at Carrick Institute. And then my personal stuff, I've got drantonucci.com, and most of my social media handles from a long time ago, they're at Brain Guru. So you can find me there, and then Plasticity is plasticitycenters.com, and they're at Plasticity Centers, and they also at Plasticity Doctors, DRS.
Right. Yeah, great. And then you guys have the International Symposium of Clinical Neuroscience coming up at the end of May, I think. So I'll be
Yeah, that's
seeing,
right. You guys are going to be there too, right?
yep, we'll be seeing you there. We'll have a booth for that. So that's always exciting. And man, talk about your elite level conferences that are put on, not just, speakers and nice hotels. Of course, you check the boxes on all those, but just the people are wonderful. I believe your wife does a tremendous amount as well as Freddie's Garcia to set all that stuff up and make sure it's seamless and everybody gets whatever they need and what they want, and gamifications, like all sorts of just fun things there. So do you know offhand who you have on the docket for speaking this year for that?
Oh my goodness, it's actually a big one. I think we've got 38 speakers.
Oh,
So
fantastic.
it's going to be a big one. It's going to be our biggest one ever, actually. Yeah, it's an International Symposium on Clinical Neuroscience, and ISCN for short. And I think this is our ninth year doing it. I kind of lost track. It's been a long run, but honestly, the symposium is become world class, and I think what makes it world class is the diversity of people that show up. I've met so many great physical therapists, neurosurgeons, interventional neurologists, experts, people that are quantitative EEG experts. It's just so amazing to kind of come together with all these different people from completely different backgrounds that are having the same conversation. The things that we're talking about today with functional neurology. I don't so know for sure who's there. I know for sure that I'm speaking. I'm going to be talking about Parkinson's disease, kind of the past, the present, and the future of Parkinson's disease, which is I see a lot of Parkinson's patients, and you would not believe how well they do. Now, this is basically a condition that before has just been nihilistic, where it's just like, oh, let's sit back and watch how bad you do, and come check back in every 6 months so we can measure your progress, and it's not progress, it's regress.
Regression. Yeah.
But these people start to become more independent. Their balance gets better. Their cognitive function gets better. Their alertness and arousal gets improved. So we're going to be talking about a bunch of that, and I know there's some other great topics on the docket, and you can actually find out more about that. It's on the Carrick Institute's website, and you'll see a big banner for ISCN. You can see everybody who's speaking there and all the different vendors, and we have a great time. You've got to come.
Yeah. Yeah. I recommend it to anybody out there looking to maybe get outside their box clinically a little bit and find something new, or those that feel like they already know a lot about clinical neuroscience. This, every time I've been to ISC, and it blows my mind just taking it in from the sidelines and a chair in the back, and just my notes are extensive of things that I write
Well,
down.
we're kind of moving towards the idea of a think tank where it's not so much didactic, like, well, here's how you diagnose Parkinson's disease. That's not what we're trying to go for,
Right.
because a lot of people know how to do that. So when you attend a conference, at least this is why I attend conferences, it's to change my current thinking paradigm. So what we do is we try to invite people that are on that next thinking paradigm to kind of share a stream of consciousness, what their research they're doing is, what they're observing in clinic, and then also kind of what's going to be the next big thing in that topic. And those are the presenters that we have that come, the people that are thinking about the next big idea in that sort of realm of their topic. So it's always, like you said, I'm even in there just scribing all sorts of notes, because I'm like, man, I got to think about this. Boom, this blew my mind. I never thought of it that way. So I always leave with something, and I've been doing this for a while.
Right. Fantastic. Well, this has been really great for me. It's been wonderful to see you again, virtually, albeit, but we're heading a good direction, it seems, with the rest of the world. Although Florida's been out in front for a while, which is
We have been.
really good. So I look forward to seeing you in May. One last quick hitter. Everything good with your family? Everybody's healthy there, doing well?
Yeah, it's amazing. I mean, I've got 5 kids. I've got a 16-year-old that's learning how to drive now. That's been fun and terrifying at the same time.
Sure.
I've got two 13-year-olds that are doing great, and I've got two 3-year-olds that are amazing as well too. So 2 sets of identical twins. So Trish is efficient in everything that she does. She's ultimate executive. It's
That's
like we
right.
got to do 2 things at once.
Yes.
So yeah, everybody's great. Dr. Carrick's doing well. We're so blessed, and we're just excited for the world to open up again, because we've got, over the past 2 years, we've been kind of cooped up and just spinning our wheels trying to make things happen. Now it's time to let it all out. So the world's going to be pretty excited when they see what's on deck here.
That's right. Well, that's great. So for everybody out there, this has been Dr. Matt Antonucci, just catching up with him about functional neurology, and make sure you go on to drantonucci.com if you need to get a hold of him directly, or go on the Carrick Institute at Brain Guru on Instagram. That's a phenomenal follow. I recommend everybody get on there, and just thank you so much.
Yeah, it's a pleasure. It's always great to see you. And like you said, I can't wait to see you again in a couple months.
Perfect. All right, everybody, take care for today, and we'll see you in the future.